Okay, we're going to talk about Cushing's Triad and treatment thereof. It's going to be just a quick, short snippet. We won't hit every subject on every slide. We're just going to kind of take some pieces out of this to give you guys a quick rundown of what it is and what to do about it. So first off, what is Cushing's Triad? It is the increase in intracranial pressure due to the accumulation of blood or some sort of mass or whatever it might be inside the skull and the brain that's causing too much pressure in there, and it might just be something like swelling of the brain. Typically we see this with head injury patients, some sort of trauma, motorcycle accidents, whatever it might be where they've hit their head. But you can also see it with CVA patients where they've got a brain bleed going on and it's causing that increase in intracranial pressure. Once you get that increase in intracranial pressure, your brain will then become ischemic because it can't get adequate blood flow because there's too much pressure. And so that sympathetic nervous system that we have, the fight or flight response, starts kicking in more and says, hey, I got to raise my blood pressure up. I don't have good blood flow to my brain. Let's get that pressure up there, constrict peripheral vessels, increase heart rate, whatever it might be. And so it's going to increase our blood pressure there, and with the attempt of perfusing the brain better. And then your baroreceptors in your body, which are in your aortic arch, your carotid blood vessels and stuff, those baroreceptors are going to say, hey, my blood pressure is way too high. I've got to lower my heart rate down to help counteract that. And so you'll get this paradox where you'll have a high blood pressure reading and then you'll also have low heart rates. And that heart rate might be 60, 50, 40. 40 would kind of be on the lower end of that heart rate there. And that's just your body's way of trying to counteract the raising blood pressure, even though it's your brain trying to raise blood pressure to increase perfusion. So it's weird how it's kind of counteracting each other once you've messed up something in the brain. And then also with the increased pressure in the brain, it's putting pressure on the medulla, which is our respiratory center, and that's where we get our irregular respirations, and that oddness there is from the pressure on the medulla. So some different things, kind of signs and symptoms there to look for whenever you do have the elevation of ICP. Just kind of a good reference chart there for you. So with this, what are we going to do to treat them? First thing we want to do is increase oxygenation. Whatever we can do to increase SpO2 readings, because why is the pressure going up? Is to increase perfusion because the brain is becoming ischemic. So whatever we can do to help the body along with that, throw them on nasal cannula 6 liters a minute or whatever it is to do the SpO2 reading up as high as we can do. And then on the way to the hospital and stuff, we can go ahead and elevate that head of the bed 30 to 45 degrees, something like that, as long as they're not on a long spine board. Whatever we can do to elevate the patient's head to kind of relieve pressure. Gravity will work against us. If you have everybody flat or Trendelenburg, that pressure on the brain is going to be greater than if you were to elevate the head and let gravity help us out. Be cautious with the fluids in these patients. Don't be giving them a ton of fluids because their pressures are high. We don't want to raise them too much more. So just be cautious in that and look for signs that they do need fluid therapy, gross hemorrhage, stuff like that. It does say on this slide here about treating, or don't allow the patient become hyperpyrexia, which is pretty much just don't let them get too hot. So kind of try the best you can control their temperature, not too cold, not too hot. Keep them normothermic there. You may see it on a transfer. It's not real common, but you may see it on a transfer of a mannitol or a Lasix drip or something like that, and that is just trying to get rid of fluids and relieve pressure in the brain. Something that we can do is benzos. Consider sedation for these patients. If they become agitated and or start having seizures, that's just going to cause that ICP to raise up even further, and we really don't want that going up any higher. So if we can give them a little bit of sedation, check local protocols with maybe a couple of milligrams of Valium or Versed or whatever to keep them nice and calm and relaxed and keep that ICP down as low as we can. Another good way to do that is turning down the lights in the back of the ambulance, keeping a calm environment in the back of the ambulance. Get done what you have to get done, get those IVs started, get them all set up, and then on the way to the hospital, sit back a little bit, turn the lights down a little bit, keep it nice and quiet, and that way it'll kind of help keep them calm and keep that environment better for their ICP readings. With these patients, we're not going to treat bradycardia. So we're not going to turn around and say, hey, their heart rate is 40, I've got to give them 0.5 of atropine or start pacing them or whatever. You want to understand why they're bradycardic. Well, they're bradycardic because their blood pressure's 200 over 120, and so don't be treating that bradycardia with stuff. And also you need to understand why we normally treat bradycardia is to increase perfusion, and that their issue is not a perfusion issue, so to speak. It's a head injury issue, and that's just the body's response to it. Hope this kind of helps clear things up. Just a little short snippet on Cushing's and some treatment for it. So hope this helps, guys.